Alright guys, so today we're talking about shoulder pain and muscle power deficits. And so when you look at the pattern, many times a shoulder impingement or rotator cuff type problem presents either as something like this, right? Subacromial pain, or perhaps something that radiates down a little bit further. And again, we recognize that pain patterns don't necessarily predict tissue pathology, but it's common in clinic that we see the patients presenting with this type of problem. And remember that in the guidelines and in the coming guidelines, shoulder pain with muscle power deficits encompasses a large spread of different pathologies. And the beauty of it is that many of these pathologies have very similar impairments that are the cause, and so we'll look quickly at that. So you can quickly look at the prevalence of this condition. Okay, we know that it's a very common cause of visits to the physician's office. You can watch a quick video of this patient, and you'll note that when you're observing this patient moving, that in fact he has pretty good range of motion, but a very characteristic arc of pain, which often occurs at around 90 degrees. So we'll take a look at his pain location. We can see some faulty movements already of how he likes to elevate his arm, but he does have full range of motion, and he complains of a few pinching type movements. So very different from someone with apprehension and inability to get to end ranges because of instability, or someone who is actually frozen or stuck. Generally, the key findings for this condition are presence of an arc of pain. You're going to do your standard range of motion assessment, so you're going to look at active and passive range of motion of the shoulder, and you're going to find that generally they have pretty good range of motion. Accessory mobility is important as well, because this is a key impairment potentially that may be driving someone with shoulder impingement, so potentially posterior glide limitation of the glenohumeral joint. And when you look at the key tests, most studies utilize the presence of an arc of pain, positive findings of at least one or more impingement tests, Neer's test, Hawkins-Kennedy's test, and then an assessment of the rotator cuff manual muscle test, or more so just an isometric resistance to assess the integrity of the tendon, right? The power production of the muscle. When you look at rotator cuff tear tests, we've organized them here for you. The bulk of them are lag signs, drop arm test, belly press test. Of course, all of them will have their research numbers here, okay, their validity numbers. And we've added in also biceps tendinopathy as well here, because the same impairments, this is also a power deficit, and the same impairments may be causing the patient's symptoms. When it comes to the movement faults, this is a very critical part of a movement specialist doing their examination. We've organized it into three main categories. So there's three main scapular faults: insufficient scapular upward rotation and elevation, insufficient scapular posterior tipping, and scapular winging or internal rotation with active elevation. And so as you observe in those categories, you can look at a posture exam, some type of correction with a special test, and then also some muscle testing that might be relevant for this scapular movement fault. You can look through each of these categories. You'll see that there are two humeral faults: excessive humeral anterior translation, as well as excessive humeral medial rotation, which you'll see in the way that the person likes to move. Essentially, this person is not externally rotating enough in their functional movement. And lastly, a thoracic fault. We do know that in order to get full elevation, it is useful to have good thoracic extension. So we can observe that and see if when we correct this thoracic kyphosis, does the patient have decreased impingement pain or a decreased arc of pain. When you look at the associated impairments, you'll see that we've added potentially thoracic stiffness as one of the impairments, tight muscles that might either create the inability of the arm to externally rotate, so these are a lot of the medial rotators, as well as some posterior capsule and pec minor length, which might create the environment of insufficient posterior tilt of the scapula, right? Would be an anterior tilted scapula. And then we have some scapulothoracic mobility issues, some scapulothoracic muscle weaknesses that we'd want to assess that are well established in the literature as contributors or actually found in people with this type of problem. And so we also added in some picture-specific impairments like GERD, posterior shoulder endurance test, some core endurance and motor control tests that are useful for your high-level athletes. When it comes to your interventions, it's important to now begin to decide which of the impairments you have found in the objective exam that you want to spend time focusing on. So, in some cases you might have to improve accessory mobility. In some cases you might need to improve scapulothoracic mobility, so the scapula is not moving well, it's hypomobile. There may be some soft tissues that you're going to have to improve the mobility of, right? So I might want to improve the length of the humeral medial rotators, or improve scapular posterior tipping by working on the pec minor, or soft tissue the posterior capsule and stretch the posterior capsule. And I may need to do some manual therapy to the thoracic spine to improve the mobility. When it comes to the therapeutic exercises, again, you can do a number of mobility type exercises to stretch and improve tissue length. But really, in the motor coordination part of the therapeutic exercises, we've broken it up into 3 phases based on the work, a lot of good work by some of our colleagues from Canada, where they're using exercises for motor control training related to the scapula. So talking about helping the patient find an optimal scapular position, working at low angles of shoulder elevation initially, and ideally working on submaximal isometrics for the rotator cuff to help with the centration or the stabilization of the humeral head in the glenoid fossa. And then as you move into phase 2, where the patient is less irritable, we're going to start moving into elevation, especially in the scapular plane, moving to 90 degrees, which is typically a non-provocative position, and ensuring that there's good scapular alignment. At this point, we are also doing a lot of exercises for the scapulothoracic muscles. And you'll see that we continue to return the patient towards function with a lot of different functional exercises in the low irritability return to function phase. Okay, so you see a number of different interventions there. That should give you a quick picture of how to manage or look at this pattern of shoulder pain with muscle power deficits. Remember that this is not a cookbook. You're going to have to do your own examination. This is just a suggestion of how the different tests play together, how the impairments may drive the condition, and also very importantly, what are the common movement faults that may drive this shoulder impingement. Remember that shoulder impingement is really a spectrum. Initially, people may complain of pain, and it's very mild pain, and it's just a standard shoulder impingement with no particular major tissue pathology. But as this problem persists, the patient may eventually develop a tendinitis, a tendinosis, or calcific tendinitis, and then eventually progress to a full rotator cuff tear. In the end, many of these key impairments are the same, regardless of which phase of the pathology that the patient is in. Okay, so that's shoulder pain with muscle power deficits.